Something to say?
Fine.
Thank you, Dr. Modi. So he's a transplant cardiologist here at UCLA. He obtained his undergraduate from Dartmouth College, his medical degree from Harvard Medical School. Completed IM residency and cardiology fellowship here at UCLA, where he served as chief cardiology fellow. He completed an additional fellowship in advanced heart failure and transplant cardiology at Cedars-Sinai. Dr. Srivastava practices evidence-based medicine and strives to incorporate the latest medical developments and technology in his clinical care. His practice spans the spectrum of cardiovascular disease, ranging from prevention, general, and sports cardiology to advanced heart failure and cardiac transplants. Passionate about clinical research, Dr. Srivastava has published broadly in the fields of heart failure and transplant cardiology. He has presented his research in both national and international forums and has received multiple awards for his work. In his spare time, he enjoys spending time with his wife and son, playing ice hockey, and exploring LA. Thank you so much for presenting Grand Rounds, and we know you're going to be leaving soon, so we really appreciate your time here.
Thank you for the fine introduction. So we'll get right into it because I know time is short. So I'm going to be talking about exercise and basically how we can use exercise as a lens to understand cardiovascular performance, both from the perspective of patients that we see every day, so heart failure patients, as well as patients we don't see as often, or some of us see more frequently, professional athletes. So I have no disclosures. So we're going to start by talking about exercise physiology, and then we'll talk about sports cardiology, and then finally the heart failure patient. So this is I'm sure a lot of you have seen this diagram before from Wasserman and Whip, so the gears diagram, essentially showing the flow of gases as they move through our system and effectively how oxygen allows us to do work. So if you follow the flow on the bottom here, oxygen comes in, obviously it goes in through the lungs, it flows through the heart, it goes through your muscles, it goes into the mitochondria, it gets metabolized as the terminal electron receptor on the electron transport chain, and then your body metabolizes substrates and CO2 comes and flows back out through your muscle, your blood, and into your lungs. Every time I show this picture, people always have palpitations. I'm sure this takes you back to biochemistry and cellular respiration. The only reason I put it up is it's really important to understand this on just a very, very basic level. And that basic level is effectively, one, you deliver oxygen and substrate through your blood into your skeletal muscles, for example, in the condition of exercise. And you undergo this process called glycolysis. So that's if you have glucose, for example, being used as the substrate. If you have oxygen, that goes into the mitochondria. If you have no oxygen, it gets converted into lactate. And the thing to note is anaerobic respiration, which is what glycolysis doesn't need oxygen to participate in, is very inefficient. So you only make 2 ATP in this setting. And once you're in the mitochondria, your different substrates are metabolized differently. So pyruvate, which is the glucose byproduct, that is the byproduct of glycolysis, goes to the electron transport chain and makes ATP, or if you metabolize fatty acids, they actually get metabolized to acetyl-CoA, and they directly enter into the mitochondria and also make ATP. The whole thing to take away really from this slide is in the presence of oxygen, you can make 38 ATP for 1 molecule of glucose and a lot of ATP for 1 molecule of a free fatty acid, which is why free fatty acids are the main source of metabolism for our bodies. And in the absence of glucose, you're sort of stuck doing anaerobic metabolism and glycolysis, and you make very little ATP or 2 ATP. So effectively, the question becomes what happens when you exercise and why do you stop exercising? And that really helps us understand how professional athletes can go a lot further than we can go and why the heart failure patient can't exercise very much. So at the onset of exercise, you use something called the phosphocreatine pathway, and you have these molecules called phosphocreatine that will donate a phosphate group to ADP, and that effectively gives you a molecule of ATP and creatinine. So when you first start doing things, you start using immediate phosphocreatine molecules in order to initiate exercise. You may see a lot of people come in or ask you about supplements like creatine. So the supplement of creatine is effectively targeting this pathway here. Soon after, you start to metabolize substrates. So your body likes fatty acids, and that's sort of the main, because it's so efficient in terms of ATP. And then you start metabolizing glucose. So you start breaking down glycogen into glucose. And proteins, unless you're in extreme starvation, are rarely used as a substrate in order to produce ATP. So as we mentioned, oxygen is needed for efficient processing of both free fatty acids and of glucose. And as you exercise, and what you may ask, like, why do you stop exercising? So as you start exercising, your metabolic demand increases, basically you burn through your free fatty acids, you start burning through your glycogen stores, and essentially you don't have enough oxygen available to keep up with your needs. Your glucose is converted to pyruvate, it can't enter the mitochondria anymore, you get lactate buildup. And it's important to note that in exercise, you're always producing lactate, and lactate is buffered very efficiently actually by the body, by everything in the body, brain, muscles, etc. But it's only when the lactate starts to accumulate out of proportion to what can be cleared that then that gets metabolized, you have CO2 buffering, and effectively the carbon dioxide builds up, you hyperventilate, and you have to stop exercising at that point. So what you should realize then is that exercise essentially becomes an oxygen problem. So one could envision that if you could get unlimited amounts of oxygen into the electron transport chain and very efficiently have a machinery to deliver substrate, that you could exercise for a very long time. And that's basically what separates, me and you from a Tour de France bicyclist, right? Is the machinery with which they can take in oxygen and deliver oxygen and efficiently metabolize and use oxygen. So a lot of you, I'm sure, recognize this lovely formula here, which is just a rewriting of the Fick formula. So normally the way we think about the Fick formula is we say cardiac output, right? Heart rate times stroke volume equals VO2 divided by the difference between your PaO2 minus your mixed venous. And you multiply that by a constant in your hemoglobin, right? 13.4 in hemoglobin. But just to understand what determines VO2 max, right? Because we're saying oxygen is such an integral part of the exercise process. So if you rewrite the Fick formula, VO2 max is dependent on your cardiac output and your ability to extract oxygen from your blood, which is basically written by PaO2 minus mixed venous O2, written as Ca here. So heart rate, pretty self-explanatory, right? So if you have sinus node dysfunction or if you're on beta blockers, that can limit your exercise capacity. Because when you look at this, you think about why can someone not exercise? So stroke volume, right? Genetic factors, if you have cardiomyopathies, contractility, preload, afterload, valvular functions, basically where we live in our daily lives. Your PaO2, which is limited more by pulmonary issues, right? Diffusion, ventilation, perfusion. Are you on Mount Everest and trying to exercise and your PaO2 is 80%? And then your mixed venous O2, which this difference, as I mentioned, basically talks about how efficiently you can extract oxygen. So there are individuals who have mitochondrial diseases, for example, or different muscle diseases or capillary density where they're just unable to extract oxygen, and therefore they have very low VO2 maxes and low abilities to perform exercise. So thinking of this framework, putting it together, exercise being an oxygen problem, you start to ask yourself, what is the more important contributor in this equation? And I think, as you guys are all aware, the population that we see is cardiac output is very important in augmenting exercise. And if you look at exactly what augments your cardiac output more significantly, it's really a drive in your heart rate. Because your stroke volume, what will happen is your stroke volume will increase in the beginning of exercise, but really it plateaus. And it's really your heart rate that goes up and up and up and up, and that drives a large contributor of your ability to augment your cardiac output overall. So when you think about exercise, right? So the athletes and individuals who have the highest VO2s on the planet are all usually professional cyclists. This is Jonas Vingegaard, who's won the Tour de France, I think, multiple times. Actually, I don't know who won this past year. The highest VO2 I think ever recorded was in the high 90s, which was a different cyclist. His VO2 I think is somewhere in the low 90s to the mid 90s. To put it in perspective, your eyes VO2 is probably in like the 30-ish range. If you're very well trained, maybe a little higher than that. So for someone to have a VO2 max of 90 milliliters per minute per kilogram is extremely, extremely high. And then, of course, on the other end, right, we have the heart failure patients who have very, very low VO2s. And, you're talking about VO2s of like 6 or 8, right? So VO2 of 90 on one side, VO2 of 6 or 8 on the other side, and sort of everything in between. So we'll start by talking about the healthy individual, so from a sports cardiology process. So there are a few of us who do sports cardiology here. We're fortunate enough to take care of most of the professional teams in Los Angeles. So the question really becomes why sports cardiology, and the whole purpose behind sports cardiology, beyond keeping professional athletes safe, is to prevent sudden cardiac death in competitive athletes. And this is the whole spectrum, right? This includes people who are in high school. This includes your sort of weekend warriors. This includes obviously professional athletes as well. And it's really evolved from this emphasis on preventing sudden cardiac death to an emphasis on safe participation in exercise. And the thing with sports cardiology that's important is these decisions have very large impacts in terms of emotional, social, even financial, right? So someone who's a professional athlete who's playing at the top of their level, who's signing, very large contracts, and you find something wrong with their heart, for example. So those have big ramifications in terms of clearing the athlete or optimizing the athlete. And the definition that we use for the competitive athlete is one who participates in an organized team or individual sport that requires regular competition against others, or as a central component, places a high premium on excellence and achievement. Here's the classification of sport. Not to offend any of the golfers or yoga enthusiasts out there, but how it's classified, at least currently, is you have sort of this increasing static component and increasing dynamic component. So, for example, sports that have weightlifting or bobsledding or things that involve pushing against pressure or Valsalva maneuver, those are more static component sports, versus dynamic component sports, of course, include things like running. And then you have things like triathlon or speed skating, which have high dynamic components and high static components. This is from the latest guidelines on participation in sport that was just released by the HA in 2025, just sort of puts it all more on a continuum. They talk more about strength and endurance, which I think makes more sense than static and dynamic. But again, long distance running on one end of the thing, weightlifting on another end, and things like rowing have high contributions of both. The reason all this becomes important, and a lot of you will see this actually in clinic and in practice, is you may have some very, very well-trained individuals come into your clinic. And, for example, when we go to training camps, we see some very interesting EKGs, and you really need to understand what is normal in the setting of intense training, what is abnormal, and what requires further interpretation and further testing. So normal EKG findings include things like increased QRS voltage, and we'll get into why that is in a second, incomplete right bundle, early repole, T-wave inversions in Black athletes, T-wave inversions in young athletes. And a lot of it is you have to understand these athletes have very high vagal tone. And so things like sinus bradycardia or ectopic rhythms are not uncommon. And all the way up to Mobitz type 1 second degree AV block. And actually, if you're in the green, you don't actually need to do anything else in those with no family history or inherited disease. If you're in the red, that's the opposite. So T-wave inversions, aside from, we'll talk about this, the V1 to V4 and Black athletes and those less than 16, are always abnormal. ST segment depression, Q waves, epsilon waves, pre-excitation, prolonged QTC, Brugada, very, very long PR intervals, Mobitz type 2 second degree and higher, PVCs and otherwise atrial and ventricular arrhythmias are abnormal. And then you have these borderline findings of left axis deviation, left atrial enlargement, right axis deviation, complete right bundle branch block. So these yellow findings in isolation, no further eval, but if you have two or more, then you need further evaluation. By no means should you memorize this. This is very easily the document, the consensus here for EKG. So generally you just pull it up and you can see what's abnormal and not. So not to spend too much time on this, but here's an example of early repolarization, right? And in the athlete, you can see there are no T-wave inversions. You see inferiorly and more anterolaterally, you can see sort of this benign early repolarization sign. You got this sort of like fishhook sign of fractionation here. Again, all sort of normal in the athlete. So this athlete would not require anything additional here. This athlete also has some evidence of LVH. Here's an example of the T-wave inversion. So remember, I said T-wave inversion is always abnormal, aside from some Black athletes and those who are young. So these would be an example of normal T-wave inversions in an athlete. So the reason this diagram here is important is because your heart remodels in certain ways in response to different kinds of exercise. So as you have an increasing dynamic component, so long distance running, as you may imagine, your heart, you have more of a dilatory phenotype. And as you have more of a static component, you have a more LVH or concentric phenotype. And of course, in those who have both, you can have both. So it's very interesting, right? Because they looked at what is normal in an athlete, because I'm sure some of you guys have been in NIL and seen some of these athlete echoes, and they don't all look normal at all. So they've looked, for example, in NBA players. This is one of the studies, and they looked at left ventricular and diastolic dimension. And in men, a normal LVIDD is about 5.8, 5.9 centimeters. So if you look at this, right, so almost half of this cohort has an LVIDD greater than 5.8, 5.9 centimeters. Some of them are really rather big. These people, you're getting up to almost 7 centimeters here. And they found that these associate with height, and then they associate with BSA. The taller you are and the higher your BSA, the bigger your left ventricular and diastolic dimension is. Here's wall thickness, as we all know, in men about 1.1 centimeters, and women about 1 centimeter. And you can see, right, I mean, a large proportion of these have thick hearts as well. and again, associate with height and associate with BSA. And here's the aortic root. So as we know, aortic root about 3.7 centimeters at the sinus of Valsalva in men, and these are male NBA athletes. So again, some of them have fairly large roots, and again, it correlates with both height and with BSA. They have all these documents that have been published on sort of normal values in athletes. This is an ASC report by Bagish et al. From 2020. But if I'm going to boil it down for you, you can, sorry, it's a little blurry. Basically, for LVIDD, there's no upper limit. You sort of evaluate in the context of the other structures. Left ventricular hypertrophy greater than 15 millimeters, and some say 11 to 13 in Caucasians, up to 15 in Black and Caucasians with large body habitus is allowed. Ejection fraction. So you have to understand that these athletes have very efficient and very high stroke volumes, and so sometimes their ejection fractions are actually decreased. So some of these athletes actually have EFs that are low, in the 45 to 50 range. So they call truly abnormal less than 45. And if you have an athlete there, the EF is about 45 to 50, you usually get stress echoes and you have to ensure that they augment to greater than that. Right ventricular dilation, there's no upper limit, but usually if your RV is bigger than your LV, that's abnormal. Your left atrium, again, there's no cutoff, but can be dilated. Your aorta, greater than 4 in men and 3 in women. And then hypertrabeculation is a really interesting thing. We see a lot of hypertrabeculation in the setting of, for example, end-stage cardiomyopathy, where the EF is very low and those forces can cause hypertrabeculation. But you can also see hypertrabeculation in athletes, and it's common, especially in Black and endurance athletes. And of course, with hypertrabeculation, everyone starts worrying about things like non-compaction, especially in the athlete. So that becomes a little bit more challenging in that setting to evaluate hypertrabeculation. So gray zone findings. So if you have thick LV walls, of course, we all know the differential for LVH. So factors that associate with exercise-induced cardiac remodeling are high static. So if you have like a professional weightlifter, for example, they're probably going to have thick LV walls. But you want to make sure there's no symptoms in the benign family history. And then on imaging, you want symmetric less than 15 millimeters. Your RV is generally normal. You could have a mildly enlarged LA, and you have normal valves. And so this sort of altogether suggests that the thickness may be just in the setting of exercise-induced remodeling. Dilated chambers, we all know the differential for dilated cardiomyopathy. This could be someone who's been like a marathon runner. Again, no history of substance abuse or family history. And imaging findings that are consistent with this being more exercise-induced is if you also had RV dilation and mild LV wall thickening, normal systolic function, and supernormal diastolic indices. We actually had this just recently in a young woman where you'll actually look at the E to A, and these might be an athlete who actually has a little bit of LVH, and their E to A is like 2.5, and that person likely does not have restrictive diastolic dysfunction. It's just these young people can have very, very aggressive diastolic filling. And the way you tease your way around that is you look at their E primes, and their E primes medially and lateral will be very, very elevated, right? And so it doesn't really suggest a diastolic dysfunction phenotype. Dilated RV, again, same thing, our differential for badness, and then high dynamic sports, and sort of the same thing we talked about with the dilated LV. I unfortunately don't have time because we want to talk about pathophysiology, but there's this fantastic document that was just released by the AHA. It was just an update to an older document, but it goes through all the different sort of conditions, cardiac, that you can find in athletes and how you clear them and how you don't. So this is a very, very nice document that was put together recently. Okay, so that's sort of exercise in the realm of the very, very fit individual. And so now we're going to talk a little bit about exercise in cardiovascular disease. So we're going to go to the other end of the spectrum. So as we said, a lot of this in part becomes an oxygen problem. And how can you efficiently deliver oxygen to your muscles and to the rest of your organs in order for them to function appropriately? And in the sense of cardiomyopathies, our biggest problem really happens here in the VO2 equation, right? In terms of, does someone have profound bradycardia, for example, or does someone have another cardiomyopathy that severely impairs stroke volume, which then impairs VO2 max and ultimately impairs your exercise ability? So we do this test, which sort of scares everyone because it's really hard to look at and interpret, called a cardiopulmonary exercise test. I'm sure all of you have seen this and are aware of this. Basically you have someone on either a bicycle or a treadmill. They're hooked up to a mask that does gas analysis. So you can measure how much oxygen they're taking in, how much carbon dioxide is being put out. It's your normal sort of stress setup. We have EKGs and breath data, and we have a blood pressure cuff. It produces this very scary 9-panel chart for most people who look at this and have no idea what to do with this. So we're going to break this down very simply not in excruciating detail, but basically we want to talk about how you can look at a CPET and understand the metabolic needs of a patient. Okay, this is a nice figure, which basically looks at metabolic consumption of oxygen at baseline. So if you look at this figure here, right? So you can see that actually like the normal and HFrEF and HF patient consumes about 3.5 milliliters per kg per minute of oxygen. And that number should sound very familiar to everybody, right? Because that's the definition of a MET. So when we talk about a MET is defined as how much oxygen you consume per minute, and it's defined as 3.5 per this, and this is what that's based off of. When you guys are doing stress tests and all this stuff, and you're looking at exercise capacity and metabolic equivalent, what you're really doing is you're asking yourself, what is the VO2 of this patient and how much oxygen is the patient consuming? And the way you're estimating that is by doing metabolic equivalence. And so that's where all that comes from. And it's a very indirect measure, right? Because you're not directly measuring it. So CPET is directly measuring VO2. So as we mentioned, again, FIC formula, in normal people, when you exercise, which is sort of this red bar here, you can see that your VO2 climbs about 9x from resting to about 30, which is what we were talking about. And of course, in HFrEF and HFpEF patients, that's significantly impaired, right? So these patients, in this study at least, the resting VO2 is about 12 and about 12 to 15, but much less than a normal individual. And then when you look at this, when we exercise, like we said, the majority of your cardiac output starts going up with your heart rate going up. And you can see these patients have higher resting heart rates and more impaired augmentation, which is the red bar with exercise. Blue is rest, red is augmentation, than a normal person. Expectedly, right, their stroke volume doesn't go up as much. And then this is their oxygen extraction, which actually isn't super significantly different than a normal individual. But again, if you're having issues in oxygen extraction, you're thinking more like skeletal muscles or mitochondrial diseases, which don't make up a large portion of studied populations anyways. So this is a very good picture and basically summarizes how you should look at your CPET from a cardiovascular standpoint. There's other fancy ways to do it too. But this is by Malhotra et al. And Jack in 2016. It's very busy, so we'll walk through it slowly. So the first thing you ask yourself when you're looking at a CPET is basically, was this a good test or not? And the way you're doing that is you want to see, did they get beyond their anaerobic threshold or their lactate threshold? And you can do that in a couple ways. One, you can look at the graphs, but generally what we do is we look at this thing called RER, which is a coefficient of CO2 production to O2 production. So once that goes above 1.1, then one assumes that your ability to clear CO2 is now above your O2, and so that we assume that to be an adequate test. Of course, in our world, we say adequate test is 85% of max predicted heart rate, which is a very crude way really to look at things. But so that's the first question you really ask yourself. And if it is a maximal test, then you look at a lot of the variables we're going to talk about. But if it's not a maximal test, there's still actually things that we can look at, and it's not just sort of a complete waste of a test. Okay. So the first thing we look at is your VO2 max, right? And so there have been studies done which effectively show that if your VO2 is 14 milliliters per kg per minute, you have very poor one-year outcomes. And so these are the patients that we consider for advanced therapies. The caveat for peak VO2 becomes if you're on a beta blocker, right? So you guys have all heard if you're on a beta blocker, your VO2, we say less than 12, mainly because as we know by the Fick equation, if your heart rate is lower, your VO2 should be lower by definition. And at the extremes of age, like very, very young, or the extremes of BMI, sometimes we'll use less than 50% predicted as opposed to just an absolute VO2 marker here. The OUES we'll ignore for now. And if you do not reach a maximal test, you can actually look at this number called VO2 at close to the ventilatory threshold, and that number less than 9. So if you look at these diagrams, so this first panel here is this first top left panel, and this is the panel on the CPET where they show your VO2. So you have time here, and then you have your VO2 here on the right side. And the VO2 is your red, and your CO2 is your blue. And you're literally just looking for the max. It's pretty easy to look at, right? And this is all reflected in tabular form. And note that this is not normalized. This is milliliters per minute, but it's not normalized for kilograms. So that's why all those numbers I showed you, just be careful to normalize it for the kilograms. So here you go. Here's a heart failure patient, right? So this VO2 max is 11. Here's a normal person like you or I, whose VO2 max is 31. And then here's like a fit cyclist, right, whose VO2 max is 44. And like I said, the best cyclists in the world's VO2 maxes are way, way above that, even double this. So the next thing you do is look for hemodynamic response. So this is kind of what we do anyways, right, in our treadmills. Here they say peak SBP less than 120, though it depends kind of what their starting blood pressure was to begin with. In general, you want your blood pressure to augment to at least about 20. And if you have a fall in your blood pressure after it goes up by 20, by more than 20, that's not good either. Heart rate recovery, what you guys see every day when you guys are doing your stress reports, less than 6 beats per minute. And of course, this is not associated with anything if this was a maximal test or not, right? If someone walked on or ran on the treadmill for 1 minute and their blood pressure went from 120 to 80, that's definitely a bad thing. The ventilatory efficiency, so this is an interesting marker. So VeVCO2, I'm sure you guys hear us talk about this frequently, is basically the amount of minute ventilation required to clear 1 liter of CO2, and exercise oscillatory ventilation. So I'm going to show you both of these things in a second, but it's interesting that these pulmonary variables actually associate with very high, greater than 20% 1-year mortality. So the VeVCO2 slope was studied in many studies actually, but effectively in this bottom study, they found that if the amount of minute ventilation it took to clear 1 liter of carbon dioxide, if that slope was greater than or equal to 36, you had a 75% 1-year mortality in some cohorts, which is quite alarming. So that really has drawn a lot of attention to this VeVCO2 slope. So the way to look at this is generally in green. You're basically graphing. This is one of the panel 6 on some CPETs. The panels sort of move around depending on what CPET you look at. But you're looking at minute ventilation versus CO2. And when this really starts to go up, this is when you're reaching what's called a respiratory compensation point. So you start to hyperventilate as the acid and CO2 builds up, so the slope changes. So it's important when you're measuring this slope is you actually measure the slope before it changes. So that the benefit of this is, as I said, if you don't reach your anaerobic threshold, it's still valid, right? Because I can just measure the slope early on, and I can see how efficient you're clearing your CO2. And so this is nice because this is a submaximal variable. So here's a normal person where your slope is 25.7 versus a HFrEF patient, right? Your slope here is 44, associated with very high short-term mortality. So exercise oscillatory ventilation is also bad. It's almost like a chain stoking phenomenon. So normally this is what, so here, we're just looking at minute ventilation over time here in this green. So, it just kind of goes up nicely. In some people, you actually see it oscillate like this, up and down and up and down, and that's very bad. So exercise also, it's not subtle, and this is not good. And then the other thing with the CPET, which is nice, is you can ask, is it a pulmonary issue? And seeing so many of these, I feel like it's almost never a pulmonary issue. It's just like, it seems like if they have any degree of cardiovascular dysfunction, it's like hard to blame the lungs, even if they may have COPD and they may have interstitial fibrosis. It's very rarely a pulmonary issue, but it's very easy to tell this. Basically, you look at what their maximal minute ventilation. So this is panel 9 on this layout, but again, different panels in different CPET layouts. And this is usually done, I think it's like 30, 35 times your FEV1, or sometimes you can have a patient sit there and just like hyperventilate right before the test as hard as they can to determine what their MVV is. I think in our patient population, that wouldn't go so well. So generally you can estimate it by 30, 35 times your FEV1. And you ask them what their breathing reserve is, right? So the question is, how close do I get to this line? And if I get to within 85, if I get to 85% or more of the way to this line, then it's probably a pulmonary issue, right? So your normal breathing reserve is about 15 liters, right? Liters on this axis, or 15% of the limit. So here's a heart failure patient, right? I mean, they don't even get close to the line. So basically, they stop exercising not because their lungs gave out. They stopped exercising because this was a stroke volume and cardiovascular problem. Here's an ILD patient without cardiovascular disease. You can see, look how close they got to the line, right? Their breathing reserve is 4 liters a minute. Their issue and the reason why their VO2 is low is a pulmonary problem. Okay, so if you go through and, when our CPETs are reported out, they have all these variables on it. So you can go through and you can read all these and you can be like, okay, you can make a determination yourself. What do you think their mortality risk is based on this? And then you can go, the green is good. So your VO2 greater than 20, your VeVCO2 slope less than 30, no exercise oscillatory ventilation, you actually have a greater than 95% survival. So I'm sure if you rotated with us in cardiomyopathy clinic, we get CPETs all the time, right? Because actually it gives you very good information in terms of prognosis and in terms of how the patient's doing. Because sometimes, these patients can't do very much. You see them in your clinic, you're like, you look fine. But only when you start to exercise them do things sort of fall apart. All right. There are different levels of CPETs. Not all are considered equal. So level 1 is your normal CPET, which we talked about. Level 2, which I don't think too many people do just level 2s, but level 1 plus an A line, and that way you can measure lactate for anaerobic threshold. And level 3 is what we do, and I believe we are the only place west of the Mayo Clinic in Minnesota that does level 3 CPETs. I may be wrong with that, but I think a lot of this is more rare. to do. But in some way, I think most heart failure programs do this in the sense that they put swans in people, and we do exercise right heart caths all the time. The cool thing about this level 3 CPET is we put a swan in and an A line in, and then we do an actual formal CPET measuring gas analysis. So it's like a very comprehensive way for your patients who have unknown dyspnea. So when you ask yourself, when you exercise a patient, what happens? Because I see a lot of people who get exercise swans, and then you're like, oh no, the filling pressures went up. This patient has HFpEF, right? So actually, your filling pressure should go up when you exercise, and there's different extents that which the filling pressure goes up. So you can see here in this one study, for example, in this patient population, their mean PA at rest was about 13, but they went up to about 30. Again, not crazy. But look at the cardiac output, right? So at rest, a normal cardiac output in this population was about 7 plus minus 2.2. But the maximum cardiac output here is almost 24 liters. So it's pretty significantly elevated augmentation when you exercise. So what they've done is, don't need to belabor these graphs too much, but basically what they've done is they graph people who have abnormal disease, and then they graph people who have normal disease, and then they try and find what is a normal increase in your wedge and what is a normal increase in your mean pulmonary artery pressure with exercise. And basically the summary of all these studies is here, right? So when you look at an exercise right heart cath, you should look at these numbers and ask yourself if things are abnormal or not. So did your right atrial pressure increase to greater than 12, or did the change in right atrial pressure over change in cardiac output go above 1.3? Did your mean PA pressure, that you look at a slope here, so it's a change in your mean PA pressure to a change in your cardiac output greater than 3. And then your pulmonary capillary wedge pressure, so did your pulmonary capillary wedge pressure go to above 25, or was the delta change in your capillary wedge over your delta change in your output greater than 2? And you can look at your transpulmonary gradient, delta TPG or delta CO greater than 1.5. So if you ever get a level 3 CPET, the pulmonary folks who run them here are extremely good. So if you actually open the report, you actually see like Excel files where they actually run these regression lines. Like they'll graph wedge versus cardiac output, and they'll actually fit a best line, and then they'll get the slope of that line in order to tell very precisely if your response to exercise was abnormal or if it was abnormal. So it's a very interesting way to do things here. Okay, so I like to bring this up. I've talked to a lot of you, I think, about this already. We get asked this a lot of the times, right? It's just like, what is accurate? Because like, I'm sure you guys have all been in the cath lab and you get a thermo and then you get a FIC and they're just wildly discrepant from each other. And you're like, what is going on? And like, what can I actually trust? So first, for thermos at the extremes of cardiac output become a little bit less reliable. And so those are difficult. I mean, some people will say TR causes you to underestimate it, and shunts cause you to overestimate it. But there are a lot of studies that actually say TR may not actually significantly be underestimating cardiac output in the setting of thermodilution. So the short answer is thermo should probably be the most accurate way to look at this. And the reason is FIC has got all these assumed variables. So this is just a rewriting of the FIC equation. Again, we put VO2 on the other side. But the VO2 is approximated by this Damer approximation, which is 125 times BSA. Now, one could argue that in that chart I showed you earlier that the resting VO2 was the same in HFrEF, HFpEF in normal patients. But when they actually go and they measure VO2s in a lot of these patients using this Douglas bag assay and basically comparing that VO2 to the Damer formula, they find that there's a lot of discrepancy. And effectively, because if you look at this, right, your cardiac output is directly proportional to your VO2. So if you have error in your VO2, then you're going to have that one-to-one error in your cardiac output. And there's actually a pretty significant error in your VO2 when you actually measure it. So this is percent error in number of patients. And so, for example, in this one study compared to Damer, 17% of patients had greater than 25% error in comparing a approximated VO2 to a directly measured VO2. So that's a pretty significant error, and it could be in either direction. And a significant portion, about 50% of patients, had more than 10% error. So it's hard to know, right? Like a 25% error could really be discrepant in terms of looking at your index. So if you get an index and someone's thermal index is 1.3 and their FIC index is 2.2, and you're like, oh, they're fine because the FIC is okay, your FIC may not be the most accurate. And I'm telling you, the thermal is likely not the most accurate either of the extremes of cardiac output. And as I say in most people with cardiogenic shock, is you have to really look at the overall patient, the overall picture, their perfusion, their LFTs, their kidney function, their lactate, etc., as opposed to just chasing one number for cardiac output and cardiac index. Okay, so putting all of this together, using exercise as a tool to really determine what is going on and what is going wrong with the patient, and you can do this using like a level 1 CPET or a level 3 CPET. And there's this really great chart actually put forth in our heart failure board review by Greg Lewis from the MGH folks. But so as I had said, you don't really need to look at all the charts and everything because that can get a little bit confusing. Well, all you need to do if you're in a rush is just look at the data, right? So you always ask yourself, was the maximal effort achieved? And you're doing this in any stress test, right? You're asking yourself, we ask yourself all the time, 85% max predicted heart rate, but this is a much better way to know was maximal effort achieved. So peak RER greater than 1.1 or heart rate greater than 85% predicted. The purists in this field will say that you really need to look at the data and see was an anaerobic threshold reached, and we say that in our CPET reports. The reason being is some people say is like once you get on a bike or a treadmill, some people just go crazy with it in the beginning. So you can, if you just went on a treadmill and I put the treadmill to 12 on a person and you just started sprinting, your RER is probably going to be greater than 1, but your VO2 is probably not going to be the maximal it was. So somewhat looking at the test as well. So little asterisks by that. So if you didn't have a maximal effort, then that obviously limits your interpretation, but then you go to sort of those non-max effort variables, right? Those include things like your VEV, CO2 slope, what are your blood pressure due to exercise, etc. Then you ask yourself, is peak exercise capacity impaired? So peak VO2 less than 80% predicted. If no, and your VO2 is normal, then you kind of have to ask yourself, well, my oxygen and my metabolic demands are being met. What else is causing this dyspnea? You think about things like obesity, for example, causing dyspnea there, or heart failure symptoms. Then you ask yourselves, is this a pulmonary problem? And like I said, in our population, it's almost never a pulmonary problem, but you still ask yourself that question every time. And you look at your breathing reserves. Some people quote 80%, some say 85%. But basically, you ask, am I getting close to my maximum ventilatory reserve? And generally, no. But if yes, then there's probably some pulmonary mechanical limitation. So honestly, just based on that alone, you've ascertained a lot of data. You can say, is it a pulmonary problem? Maybe it's more of a cardiac problem. Like I said, it's very rarely something like a mitochondrial problem or a skeletal problem. But after that, if you really want to ask, and we have all these patients who have like unknown dyspnea, whose echo's fine, filling pressures are fine, they may have a little bit of ILD, and you're like, well, what is actually going on? So then you can refer those patients to invasive CPET, and then we do the invasive CPET, and then this is just being thorough. Again, very few people have like an extra oxygen extraction problem, but is your extraction abnormal? So do you have some sort of problem with like actually getting the oxygen out of your blood? Like your PaO2 is 98 and your mixed venous O2 is 96, right? It's just like, clearly I'm just not able to extract the oxygen there. Then you ask yourself, you exercise the patient, and using exercise, you can very clearly tell them like, what is the issue, right? So is this just chronotropic incompetence? You know, there's a lot of studies coming out now in HFpEF patients who get put on beta blockers. They have very bad exercise tolerance and exercise capacity and symptoms. So say you start to exercise someone and their heart rate goes from like 80 to 90. You know, well, that may be a reason why they feel poorly when they exercise. Is there RV dysfunction? Or is there pulmonary hypertension, right? And like we said, you'd look at the delta PA over the delta cardiac output to be greater than 3. You don't just say like, oh, this patient's mean PA pressure rose to above 20 with exercise. They have exercise-induced pulmonary hypertension. They have HFpEF, right? Because as I said, these numbers are all supposed to rise, and it's really a proportion of the rise in comparison to your cardiac output. And then you can assess, as we do normally, right? Is this pre-capillary or post-capillary? So does your wedge rise inappropriately, or does your PVR and your transpulmonary gradient rise inappropriately? And that can help you sort of tease it out. So this, I think, one slide I really like because it kind of puts everything we talked about onto one piece of paper, and it can really help you have a better nuanced understanding through the use of exercise of how the heart failure patient operates. Okay, so in summary, your exercise capacity is dependent on your body's ability to efficiently transport oxygen from the lungs to the mitochondria of cells. The field of sports cardiology we talked about in one spectrum is concerned with preventing sudden cardiac death and providing eligibility and disqualification guidance for participation. It's important for the cardiologist to be aware of imaging changes in competitive athletes. And then as we spent the last little bit talking, exercise physiology can provide a very unique insight into the prognosis and management of the heart failure patient. That's all I got.
With long COVID patients, have you seen any changes in this population for O2 extraction?
That's a great question. I'll have to defer that question to maybe Jeff, Sue, or Megan. I don't know if either of them are on, who see the long COVID patients. We haven't seen too many of them. I'm not sure, actually. I don't know the answer to that. Sure, do you know?
I don't, other than a lot of the patients that Jeff ends up seeing will have, I don't know if he's on the call, but a lot of patients that he'll see or that Dan and I have seen when we rotate in the clinic will have some dysautonomia. So their heart rate will go up very fast. And that is a limitation for their ability to extract oxygen. And so one of the ways that we can counsel them is to give them a graded physical therapy program, meaning that they start with their exercise recumbent. And then over about a 3 to 6 month period, they basically start to go more and more upright. And that's called the Levine protocol. So if you ever have a patient who has either POTS or long COVID related dysautonomia, you can just Google Levine POTS protocol and give it to them, and they can guide their therapy from there.
I mean, interesting. I'm sure interesting to see if there is data on long COVID CPET studies. I'm guessing their VO2 is probably impaired, but I'm not sure. I'm not aware of that data.
I think there's a mitochondrial dysfunction as well.
Yeah.
At the fluid level. On that same note, oh, please go ahead.
Sorry, this is Holly on Zoom. Pratt, that was wonderful. Thank you so much. And my question is, when I was, early on in training, the thinking in heart failure patients was that, yes, they're limited by their heart, but most are actually limited by a deconditioning, a skeletal myopathy. And that was the reason, like after transplant, patients didn't just get up and start walking several miles, but they had to go through cardiac rehab. Can you speak to that? It's not strictly a mitochondrial issue, but is that still thinking, or has that changed?
So I mean, I think obviously if their EF is 20%, a large proportion of the limitation is from the heart. But I agree. I mean, any kind of deconditioning or inability to efficiently use the system contributes to things, and cardiac cachexia and loss of skeletal muscle chief among them. So I think, yeah, that's definitely still thinking. But a lot of them, as they get better after transplant with the cardiac rehab, but I think a large component, of course, is us replacing the heart as well. But that's another reason, like, for example, patients who are obese will have higher VO2s than one would imagine. And they can be very, very symptomatic. And actually, their VO2 can be in the normal range. And you got to sort of have a keen eye for those patients because their metabolic cost is just much higher due to, sort of the other end of the spectrum, adiposity and those sorts of things. And so that definitely plays a role too.
My question is dovetailing off Holly's and Dan's points, which is how can you use the CPET here to prescribe an exercise program for your heart failure patients who you might not be considering for transplant immediately?
So, I think this has perhaps been looked at a lot in the setting of like ischemia, like where we'll say, you can either look like a stress test and see where people get ischemic. For these patients, you can start looking at things like ventilatory thresholds, and then you can see that when above the ventilatory threshold, obviously they're exerting much more work and lactate is building up. And so then you can look at heart rates at the ventilatory threshold, and then, or you can see exactly how much VO2 they spent at the ventilatory threshold, convert that to METs, and then give them an exercise prescription that's analogous to that. So, very low ventilatory thresholds would be, maybe you can walk around and do household chores, or maybe your ventilatory threshold is much higher, then you can perhaps use it in that setting as well. Though in general, for these heart failure patients, as long as it's not dangerous and arrhythmias, you try it. The whole point behind cardiac rehab and everything. Your goal is really not to severely limit their activity. I think it's different than like someone who's ischemic and not revascularized. But in terms of you kind of want to push them and to make their system more efficient and improve their skeletal muscles in order to get their VO2 and their ventilatory threshold higher.
When I counsel my patients in clinic, 30 minutes of moderate intensity exercise per day, go for a walk. How can I make that better and give them a little bit more guidance on what kind of exercise?
I think it has to be very tailored to what they're able to do and like what brings about shortness of breath. I think in these settings, cardiac rehab becomes very informative and very useful because they're graded exercise programs and you're able to they're able to push themselves more. As I think all of us know, right? If you go try and exercise by yourself, it's hard to like sort of push yourself and see what's safe and what you're kind of capable of.
Sort of the athletes who who have different types of stresses that lead to different types of remodeling. Have we seen if any of those remodeling down the line causes are associated with more negative outcomes?
So that's what a lot of these papers were getting at. And a lot of them, if you're within sort of the realms of normal remodeling, the thought is it doesn't lead to adverse outcomes. And the thought is you don't limit or you don't restrict these athletes. And I think that's where history is very, very important, right? And it's just like family history, their own history, family history, things like cardiac death, in NBA athletes, a lot of them we see Marfan's becomes like a big thing, right? Because a lot of them have dilated aortas, and now you're like, well, okay, you maybe Marfanoid appearing, maybe that'll be dilation, dilated aorta, sort of what's going on from that standpoint of things. So a lot of additional imaging sometimes, like when we're not sure, we'll get a lot of cardiac MRIs on these patients, or you'll do stress echoes on these patients if you're sort of in this gray zone where you're like, is it pathologic or not?
Right, that was fabulous. So, quick question. I just want to challenge you. So, invasive CPAT.
Yeah.
West of Mayo Clinic.
Yeah.
UT Southwestern.
I don't know.
National Jewish.
Yeah.
I bet that I'm thinking those two might do it. But
Yeah,
yes,
they may. I mean, I think the way to. I think every heart failure center probably puts a swan in patients and exercises them. So in a way, it's just the only difference is you're putting like the gas exchange mask on the patient, and you have them doing like the formal CPAP protocol. But I think every institution does like exercise right heart cath.
Right.
The cool thing about doing the invasive CPAP is it's very controlled.
Yep.
And the data you get is very, very good. And based on actual getting lactates from the A line, you know that the patient had a maximal effort. And then therefore, because a lot of the times, and the other challenge a little bit is a lot of these CPAPs are done on bicycles, which is very foreign to people. And so their VO2s are actually a lot lower just because you don't know how to efficiently use your muscles to ride a bicycle properly. So a lot of the heart failure literature, actually, the VO2s are done on those ones are done on treadmills. And even for you or I, if we were to do a CPAP on a bike, unless you're like a professional biker and a treadmill, your VO2 would be higher on the treadmill than it would be on the bicycle.
And can you give us an example as like an advanced heart failure specialist, how you would use invasive CPAT hemodynamics to alter medication?
So I think one case we had was a patient with scleroderma who also had HFpEF, normal filling pressures, but very, very short of breath. And so we went and we did the invasive CPAT and actually didn't have very significant rises in filling pressures at all, but she was one of the rare patients who met this MVV cutoff threshold. So we're like, okay, you're impaired from a pulmonary standpoint. The other way to think about it is if you have the patient, and we've seen all these, like say you have a HFpEF phenotype patient come in, the BNP is completely normal, which it can be in a good proportion of HFpEF patients. And then the echo is normal, and every time they say, well, every time I exercise, I just get short of breath, I don't feel good. And you do the invasive CPAT and you prove that the filling pressures are elevated in that setting. I think this is a fantastic place to use things like SGLT2 inhibitors, if they're obese, GLP-1s. At that point, once you've proven HFpEF, and a lot of these patients have bad hypertension, I'm convinced Entresto is the best hypertensive medicine in the world. I put them on things like Entresto, and then actually they end up feeling a lot better. So that's kind of how you would use the invasive CPAT in that setting. Some people will do these like diastolic stress tests. So for example, like you get an echocardiogram and you look for increases in your E to E prime as a proxy for filling pressures going up. A little bit of the challenge to those is that, again, if your E to E prime goes up, I don't know how much it's gone up in relation to your cardiac output. And as we noticed, there's different ratios of what's normal and abnormal. So just your E to E prime going up, I mean, a lot of our E to E primes may go up, in that setting too, because it doesn't necessarily mean a pathologic rise in left atrial filling pressures. And so I think it also provides a little bit of benefit from that standpoint.
I agree.
That slide with the normal EKG equifying is and realistically, how are you interpreting or applying these to patients? Because not all athletes are the same. Kind of like the golfer is going to have very different. Like, is there like how do you tell? Oh, this T-wave inversion is like actually normal for somebody like you?
Right. Well, T-wave versions, again, like I said, almost never normal. But you're probably talking about something like, say, so you have like a very young athlete who comes in with like an ectopic atrial rhythm. I think it's all tailored to who you're at, like, Dodgers training camp, or you're at just in your clinic and you're seeing someone who just goes to the gym once a week. Those are very different. So you have to ask yourself, is the amount of training enough to explain these things? I mean, you'd be surprised how well trained some people are. So you kind of got to tailor it one way or the other. And then, you got to treat them like just any other patient. If your degree of suspicion is pretty high and you get additional imaging, for example, a lot of this is in the setting of screening, which, countries like Italy, for example, implemented a mass EKG screening program in the very beginning, versus other countries like Israel didn't actually find benefit to EKG screening programs. And, we as I can show you this here. So this is Italy, nationwide screening program. And the point here is cardiovascular deaths are actually very, very, there's not a lot of them. So there were these athletes were followed from 1982 to 2004. Right. And there's 55 cardiovascular deaths in that whole period, but they were able to reduce sudden cardiac death by about 89% from 3.6 to almost nothing by using just like an EKG screening program. The Italian population has a higher incidence of arrhythmogenic cardiomyopathy, so perhaps that's why they saw that. But this Italian data wasn't replicated in Israel. And in the US, there was no sort of benefit to these EKG programs. This old recommendation from before was basically saying don't do EKGs, but I think now the more current recommendation is it's reasonable to do an EKG and an HMP. And then, for example, here's an example of all the professional teams and like what they require, HMP echo. So some of them are much more aggressive. So you can see like the MBA, you get echoes and stress echoes on people versus the MLB is the least, right? So it's like sort of more HMP and EKG, and then if abnormal, you do other things. But depending on what league you're in, these are the different sorts of testing that they like to get.
Like in the genetics world, I'm just sitting here wondering, like, because exercise does have harm, has been shown to do harm in people, not in everyone. How do you reconcile not knowing their? How do you reconcile young patients potentially doing exercise that may harm their own health? And
Yeah.
and then the EKG is being labeled as normal. It may be normal for the Gaussian sense of normal,
Right.
but it may be a stressed heart. But most people have the genetics that can tolerate that stress and never lead to a arrhythmic event, right? But there's going to be a very small minority of the individuals that are going to sustain a lot of risk.
I think this question comes down to just like testing in general, right? It's just like as an extreme, like full body MRIs or these other things and resources available. And you're right. I mean, in certain populations, like in Italy, like a lot of ARVC, and that's why they get EKGs in everyone. And basically they were able to get it down to nothing. So it's tough. You got to kind of look at it in a utilitarian sense and a resource sense. So to put things in perspective, right? So sudden cardiac death in athletes is very rare, 1 to 80,000 to 1 to 200,000. So it's 5,000 times less than motor vehicle accidents, less common than suicide, drugs, homicide, and it's similar in frequency to a fatal lightning strike. But as you mentioned, the thing is the community impact is significant. I'm sure everyone remembers, right, when athletes die on the field in the NFL, or especially in like a high school or college community, it's devastating. And everyone's always like, we need to do something different to find these athletes. And you're dealing with a very sensitive group overall, right? A lot of these are very young people. And obviously we do want to prevent sudden cardiac death in these young individuals. And so that's why a lot of these screening programs have been put into place. To the question of we should get genetics in everyone, I think it's challenging, right? It's like opening up the.
No, I'm not advocating for it by any means. But
you're right, it's hard. You'll probably miss something.
I just like when I see really abnormal looking EKG, but it's considered normal.
Right.
But how should we call it normal, or should we call it within acceptable range for an athlete of this intensity?
Yeah.
And so that people don't think of, the more exercise you do, the healthier you get. A lot of commoners think that the more exercise you do, the longer you live, which is not necessarily so, right?
I think though, to address the EKG question, it becomes hard because, for example, like when we screen a lot of these athletes, sure you've been there too. It's just like you and Holly as well. So you sit there. I mean, a lot of these EKGs are not normal, and so it'd be tough because then if you were to then call all of those abnormal and then mandate additional testing in all of those patients, I think it'd be challenging. And then that, of course, you may find other things. So I think that's what led to a lot of this sort of table and chart, acknowledging that you're right, there may not be a zero risk of sudden cardiac death in someone who has these findings because they may possibly be abnormal. But at least our guidelines and recommendations don't recommend, for example, genetic screening if you have T-wave inversions in a Black athlete in V1 to V3. Or echoes even in those patients, that kind of thing.
You wouldn't even get it.
Not if you're within the realm of normal, no. No additional testing is recommended in these settings. Of course, you ask them and they're like, oh, I'm lightheaded and dizzy and pass out and family history of sudden cardiac death, and then we go full force and we just treat it like a normal patient.
So sometimes, how come versus the athletic heart, you have them stop exercising and the echo gets normal. Does the EKG normalize also?
I actually don't know the answer to that question. I'm not sure if Jeff's on it, he knows.
He's running the ACC Care with Athletic Heart. Right?
Yeah. So he's
Definitely right now.
But yeah, we should. I don't
talking about that.
I don't know the answer to that question. But I will say the whole thinking in hypertrophic cardiomyopathy and exercise has changed from one of, we can't let people do exercise, to really like a risk benefit stratification. And a lot of these patients have very good tolerance actually for exercise. And so
I can tell you, at least for the ones we read, I mean, I think if anything, if there's already just profound degree of ST depression or two inversions, I don't know, I gotta make it non-specific. I'm sure there's evidence that you could see subclinical ischemia from demand from like just oxygen supply mismatch from too much cardiac reserve. But how much of that is non-specific or rate related? We really can't comment on that.
Well, again, what I'll say is in the athlete who has significant hypertrophy and T-wave inversions, and again, if independent of these young athletes and black athletes, I mean, the T-wave inversion is generally always abnormal. So if you have like a thick LV and you have T-wave inversions, then generally that gets investigated a little bit further. And we do get MRIs in a lot of these patients, not a lot, but anyone we're like very unsure of, then they get cardiac MRIs just to make sure we're not missing anything.
There's an elevated high sensitivity troponin cutoff.
Yeah.
Coming to the picture.
I will say I don't think we test we don't really send that line very frequently, maybe because we don't want to know what it is. I have had people who work out a lot who have elevated high sensitivity troponin. It can be 80, it can be like 100. And then, I think we were seeing one of those individuals too. And then so you tell them to stop exercising and try and check it there. So it's hard to know, right? It's like I think this guy like swims like 2 or 3 hours a day. Right, and then he goes and checks his high sensitivity troponin. I don't know. Maybe our high sensitivity troponin would be 80 after swimming that much. I'm not sure, but we don't routinely check high sensitivity troponins.
No, white.
Again, I think it's all a balance, right? It's just like you're trying to.
I'm not an athlete, so I feel like a lot of people who do sports cardiology, they're biased towards exercise and they don't want to know. So.
Yeah, I think these guidelines, we're trying to not do too much testing, and because I think it's like hard to know what to do with some of this information. So during the time of COVID is a great example, right? It's like you're getting MRIs on all these athletes who had COVID and they have some LGE, and you're like, is it COVID? Is it myocarditis? A lot of these athletes just have LGE anyways, right? We're telling you these athletes have hypertrophy and eccentric remodeling, and like, what do you do in that situation? And a lot of these decisions become very high stakes. And it's just, even if you're thinking about like a high school athlete who's going to go like to college for Division I sports, right? It's just like, to us, that may be okay. Oh, no, you can't do that anymore, right? But these are devastating blows, and you take it all the way up to some, very high profile people, and you need to be very careful in terms of what is normal and what is abnormal, of course, within the realm of safety when clearing these individuals.
All right, we're gonna let you congratulate.
Good to see you.
I'm going to Sharp there.
Okay.
Yeah.
Okay. Yeah.
Yeah.
Good place.
Yeah. No, I think it'll be good. Much smaller, much lower, slower pace. Kind of all of them. The main hospital, one kind of like the Mission Hills or Fashion Valley. Yeah. He's at the same